sir, as we have a lot discussed regarding the atrial fibrillation from the cardiovascular point of view. Now, this is a neurological point of view. Also, we want that the stroke is definitely it's one of the major concern as a neurologist that you have found in your patients. But always we are talking about the prevention of a stroke in AF patients. So, according to your point of view, what is the importance of a primary prevention, and if it's not happening, then what is the need of the secondary prevention in a stroke in AF patients?
So, from stroke point of view, like TIA, mini strokes or ischemic strokes, atrial fibrillation is one of the main causes which causes stroke, and unfortunately, it's not picked up well enough in the general population, and even if it's picked up, not all of them end up getting the right treatment. So until recently, warfarin was the mainstay treatment, but with the arrival of the newer anticoagulants, especially Rivaroxaban, which is easy to take because it's a once daily preparation, it's going to change the whole scenario, I think, with anticoagulation. In terms of primary versus secondary prevention, I think compared to the lot of trials which has been done looking at primary prevention and so on. So the BAFTA trial, which looked at aspirin versus warfarin, clearly sort of prove that anticoagulant is the way to prevent a stroke if somebody has atrial fibrillation. We have got multiple clinical studies looking at anticoagulation versus antiplatelets. Recently, with the arrival of all the NOACs, the Rocket AF trial clearly demonstrated benefit, non-inferiority versus warfarin. And also the XWORD trial confirmed the use of Rivaroxaban prevents sort of cardioversion stroke incidents to a great extent. And as you all know, it's been approved in DVT prophylaxis in knee and hip replacements and so on. And definitely the bleeding risk is comparably very low compared to warfarin. So I'm a big fan of Rivaroxaban.
Okay, so definitely, so it's a very strong point has put on a Rivaroxaban that it's one of the good molecule for the secondary prevention of stroke also as well, and as well as the primary prevention and the DVT treatment and prophylaxis part also as well.
So in terms of secondary prevention, obviously it depends on the size of the stroke. Yeah. If somebody has a big stroke, I would wait for up to 12 to 14 days and then reevaluate to see when it can be restarted. If it is a mild stroke like a TIA or a mini stroke, I would even start within 24-48 hours or up to 7 days after. And as you know, there are patients who may have a hemorrhagic stroke but still have atrial fibrillation. Okay. And in those patients, we still have a little fear in causing a major hemorrhage. So in those patients, it has to be evaluated on a case-by-case basis, and then a decision has to be made very carefully.
It's definitely, it's very well said. Now, the second concern regarding that, when the acute ischemic stroke is developed in AF patient, then there is definitely two kind of the management is there. One is the medical conventional part and also surgical part also as well. So according to your point of view, how you will stand both the kind of treatment for the treatment of stroke in AF patient?
So when you say medical versus surgical, the surgical part is very little. So for example, those strokes that need surgical intervention are like hemorrhagic strokes or patients who have subarachnoid hemorrhage and so on. In a minority of ischemic stroke patients who will develop malignant MCA syndrome where the whole brain swells up, they may need a hemicraniectomy. In those patients, obviously, it's not advisable to start anticoagulants straight away. In those patients, we would bridge with a similar factor Xa inhibitors like low molecular weight heparin and other molecules to sort of tide over the acute phase, and then we can carefully restart it. Obviously, you have to take everything into consideration, like the renal function, liver functions, the patient's age, and other drug interactions that can be affecting the drug's metabolism and so on. But so far, we have not seen a major negative impact with the newer oral anticoagulants. So I think if you choose your patients carefully and monitor the coagulation profiles, so it should be fine.
Okay. So I think it's a very well crisp but in detail discussion regarding a secondary prevention of stroke in AF patients. So the NOACs still has a very good scope in this particular segment also as well. Though the already patients when the neurologist part is also there, patient is coming with a stroke and you have to find out the retrospectively that patient is landing up with the AF or not. but still in this kind of the patient there is a very high chance of the recurrent stroke as well, and to prevent that recurrent stroke the NOACs is one of the major role. And the sir has put a very well point on the Rivaroxaban, that with the ROCKET-F data and expert data is available, it can be a better option as compared to the other NOACs. And regarding surgical aspect and medical management, the medical management still it's a on the major side as compared to the surgical segment, where there is a there is a hemorrhagic kind of stroke, then the surgical role is much higher as compared to the NOACs. So sir, with this note we are ending our discussion. So thanks a lot Dr. Shivrajan